Accurate EEGs can only be obtained from accurate setups. You're reporting accurate data, and that starts with us putting the leads on correctly. We're the ones that need to be documenting it, observing, asking questions, like actually talking to the patients, talking to the nursing staff that might be at bedside at the time that can see things that the camera isn't picking up. If we as techs are doing our jobs the best we can, we could put enough in there that they don't actually need that video.
Brad Beauchamp, thank you so much for taking time out of your asset day. You're attending at Asset. Today we're going to talk about something pretty cool. We're going to talk about the clinical manifestations of seizures and the clinical origins and how they're different.
Yeah.
So first of all, thank you. I appreciate you coming on.
Of course, glad to be here. Glad to join part of your growing media empire.
Well, thank you very much. It's super fun. It's been a crazy ride, and hopefully it grows. So thank you so much for that. Are you having fun here at Asset?
Yeah, so far so good.
Yeah, it's pretty great.
It's good turnout. Everyone's booths are getting fancier each year, it seems.
It's wild.
Yeah.
It's wild how crazy the booths are actually getting. Yeah,
for real. Now we're taking all the way up to ceiling space with signs. So yeah.
Well, Brad, okay, let's dive into it.
Yeah.
Let's get into some really fascinating educational stuff. So my first question for you, for those who are unfamiliar, can you explain the difference between clinical manifestations and the origin of seizure activity?
Yeah, absolutely. Easiest way to explain it is with the simplest example.
Yeah.
So most techs will be familiar with the homunculus. Pretty creepy looking picture with the body parts attached to the regions on the brain.
Like the sectional cortex with the tongue and the arm.
Yeah, where you have like the really big mouth that's sticking out and then like the tiny arms and legs. Yeah, it's kind of odd looking. But let's say we have a patient with simple partial seizures that are totally just purely motor affection. So that would be coming from the cortical area directly associated with the area that's exhibiting some kind of clinical signs like twitching, jerking, spasms, things like that. So we take the example of a patient that's just having left hand twitching. We can look at the homunculus and we can determine that the epileptiform would be coming from the contralateral somatomotor cortex. So that's going to be around the precentral sulcus, and it's about halfway between the midline and the temporal lobe. So that's going to be left-hand twitching about C4.
Okay.
So that's an easy way to just like correlate. Here's where we know the brain maps your hand. You're seeing hand twitching. That's where you're going to see activity.
Yeah. Now, why is it so important for that distinction whenever or an epileptologist or a neurologist is actually trying to diagnose and treat this epilepsy?
The clinical manifestation may point you to an area of the brain, but it doesn't necessarily reveal the true origin. So a seizure could start somewhere much deeper, or somewhere that doesn't, like it's not on your motor cortex. So you're not going to see an obvious outward clinical symptom. Yeah. So it might start somewhere that is not showing us anything, and then move to an area where we start to see it. And so it's understanding that just because we're seeing left hand jerking doesn't mean it started there, but eventually it reached there. So you might have to do a little more digging to figure out, okay, did it start somewhere else where we couldn't see it clinically? And that's where you want to look at the EEG, look at potentially like intracranial electrodes, see, is it coming from somewhere else first?
Yeah. Now, so the EEG, that's just the leads on the head. Where are the limitations of that compared to the deep, like you said, the deep needle stuff? Like, is there stuff that the deep needle EEG can pick up that the scalp EEG can't?
Absolutely. Yeah, scalp EEG is fairly limited in picking up surface activity.
Yeah.
Once you get a little bit, just a couple layers deep, you're getting non-specific findings. You might see some slowing. You might see some fast activity. You're not going to see obvious epileptiform.
Yeah.
So that's where you kind of you have to, if you're seeing some kind of clinical signs, or they're reporting the feeling of symptoms, but you're not seeing an obvious correlate on the EEG, that's where you might have to look further than scalp electrodes. You might want to do some imaging first, or if it's to the point where we're pretty convinced that it's seizure, but we're just not getting electrographic correlates to it, that you might want to consider inserted electrodes that actually get near that potential point of origin.
So that's when they become a phase 2 candidate.
Right.
And phase 2, for those who might be unfamiliar, is when the needles go in or the grids go into the brain. Is that right?
Correct.
Yeah.
And at that point, it kind of becomes, is it worth it? Like, is localizing it further going to provide any benefit, or is the treatment going to be the same if it's in one area versus a couple centimeters over?
Yeah.
So that's where, if you don't want to consider someone for a phase 2 and a possible resection or something like that, and put them through a neurosurgery, if it's not going to change any outcome.
Yeah.
So you kind of want to first consider, is it worth it? Would it change anything? And then if you want to get a much more detailed look at exactly where it's coming from, potentially getting a resection or something like that, that's where you want the stereo EEG.
Incredibly important, absolutely. Let's move on to like seizure onset zone and EEG. So how, can you walk us through a case where the EEG showed one thing, but the clinical symptoms maybe pointed somewhere else?
Yeah, so that can happen for a few different reasons. So one that I'd already been talking about was the deeper origins.
Yeah.
So we don't actually see anything happening clinically until it propagates upwards towards a place that we can actually record. So in this scenario, clinical symptoms may not begin until the seizure is actually fully propagated to a place we can see it. There's also a fair number of seizure foci that can start or can cause a clinical symptom that's counterintuitive of what you might expect. So for things like unilateral automatisms or unilateral eye blinking, so picking up clothing, just blinking one of the eyes, that's not from the contralateral side, that's from the ipsilateral side.
Interesting.
And so there are a few that have these counterintuitive origins where it's more of you need to kind of memorize the chart more than anything just to know, okay, this isn't really pointing to what I think it does.
Yeah, absolutely.
Yeah.
Okay, so Brad, how does a neurologist actually interpret seizure semiology along EEG data?
So I can only speak to this a little bit as I am not a neurologist by any means.
Disclaimer.
Yes, big disclaimer on that. But one of the main things they're looking at is whether the clinical semiology matches what we're seeing electrographically. Sometimes it's pretty straightforward. What we see outwardly is what we see on the EEG, and it's simple. Like we can treat that based on those things.
Yeah.
But there are times where they don't match, or what we're seeing is definitely not correlating with what's on the EEG.
Yeah.
And that would require further investigation. If it's something where we're concerned that maybe it's because it's propagating from somewhere else.
Yeah.
I mean, you can look for signs like one thing that would be worth considering is take that patient with the left hand twitching. Maybe prior to the left hand twitching that we see, they report a tingling sensation.
Yeah.
So that's actually saying, okay, it gets to the motor cortex, but it's starting in the somatosensory cortex and then kind of jumping across the sulcus to the other side. And so that if you're thinking about resections or things like that, that's incredibly important. In just general treatment, doesn't matter so much. They're going to look at these considering what the outcome might be or what they're trying to do.
And so that really goes back into the whole phase 2 stuff and looking at it in a different way.
Right.
Yeah, absolutely.
Yeah.
Okay, well, so you mentioned you're not a neurologist. That was your disclaimer.
Yes.
You are a technologist, a registered tech. How can a tech actually help in capturing these seizures and help with the documentation portion for a neurologist?
Accurate EEGs can only be obtained from accurate setups. So it starts with that. Are we recording accurate data? And that starts with us putting the leads on correctly. And from there, we're typically the one behind the computer the whole time.
Yeah.
So if something is happening clinically, we're the ones that need to be documenting it, observing, asking questions, like actually talking to the patients, talking to the nursing staff that might be at bedside at the time that can see things that the camera isn't picking up. All of that documentation falls on us.
Yeah.
And so if we provide the neurologist with great video and great EEG, but then no descriptions of the things that they can't see on video, it's not going to help a whole lot. So we have to hit every aspect of our job correctly to provide the data to the neurologist that they can really act on.
Yeah, so whenever you have a neurologist looking at the EEG, what you're saying is they don't necessarily have the video pulled up all the time.
Oh, right.
And they're just going through the EEG. And so a lot of neurologists, whenever they pull up the video, it's because they want to clarify, if you will, if it's, artifact or if there's something kind of happening around the patient that's causing this pattern. But if an EEG tech actually types in nurse at bedside doing cleaning teeth or whatever. A neurologist can look at that and look at the artifact and already make that assumption. Doesn't have to take the time to pull that video out.
Right.
Yeah.
So I mean, most neurologists will do their due diligence and look at the video for anything they potentially are concerned about. But if we as techs are doing our jobs the best we can, neurologists may never have to open the video.
Yeah.
If we describe it well enough, we can put enough in there. They might open it up out of curiosity, but we could put enough in there that they don't actually need that video.
Yeah, absolutely. Because sometimes the description of what's happening in real time is better than what they could probably look at on a video. Because sometimes it might be a little bit blurry when it gets transferred over to Citrix or whatever, and they're looking at a past recording. So I think I agree with you. I think as a tech, if we document properly, if we do everything we can to make sure that neurologist knows exactly what's going on in real time, and then we also have sometimes the luxury of having audio. So
the audio does help a lot, especially if you're in an EMU and you have a good rapport with the nursing staff. You can talk to them and they know, okay, when I go in the room, I'm not going to expect a call from you. I'm just going to say out loud the things that I'm seeing.
Exactly.
Then you can basically just be the stenographer there and just, as they say things out loud, type it into the EEG. And you're getting direct observations from the room at bedside, even if the nurse is standing in front of the camera.
And incredibly valuable for a neurologist. And listen, if I have a family member, I want a less stressed out neurologist.
Yes.
I want him to do as little things as he needs to do, weed through as little as he needs to help figure out what the issue is.
Right.
Whether it's on me, whether it's on my family, I want him or her to have that flexibility.
Right. Yeah. And if they have to read hundreds of hours of EEGs a day, if we can narrow down to maybe the 50 hours of the most important, they can put more effort into the parts of the EEG that are the most relevant.
Yeah, absolutely. So what does a neurologist typically do when they aren't able to figure out what's going on the EEG, whether it's phase 2 or scalp EEG, but the clinical symptoms are very clear?
So there are a couple things you might consider. One would be, let's look closely at what the clinical presentation is. Because there are some clinical symptoms that are more associated with PNES than they are with like electroclinical seizures.
And for those who are unfamiliar, give a quick rundown of what PNES is.
So PNES is basically similar to conversion in psychiatry, psychology, where it's not epileptiform activity that's causing a clinical presentation of a seizure, but it might be a psychological thing that is presenting itself in a way that appears physical, appears seizure-like, but it is not.
Yeah, it's not explained electrographically in the brain.
Yes, exactly.
Yeah.
It is coming from something else. And so we typically consider seizures the ones that we can point to an electrical origin.
Right. So that would be something that you would look at if there were no EEG changes on the brain.
That's the first thing I'm looking at.
But the clinical symptoms are there.
Right. The first thing I'm looking at is, okay, are these clinical symptoms that are associated with seizure, or are they ones that tend to be more associated with PNES? So things like ictal weeping, so crying during a seizure, anterior tongue biting, pelvic thrusting, and certain non-rhythmic, non-purposeful just shaking.
Yeah.
A lot of those things will point towards something that is not from epileptiform.
Right.
It's coming from something else.
Yeah.
Yeah.
And a clinical seizure, when it is caused by epileptiform, when it's originating from the brain, abnormal firing from the brain, I think there's a clear understanding of what that looks like versus PNES.
Right, because in PNES, we're not expecting to see anything abnormal on the EEG.
Yeah.
Now, if we're looking at a clinical presentation that doesn't indicate PNES, but we're still not seeing anything on the EEG, that's where you have to start considering next steps. So are we going to get some imaging, see if there's any kind of lesions deeper that we're not really picking up on the EEG, or that are a non-specific finding on the EEG?
Yeah.
Can we do a med trial and see, okay, if we give a medication that might just like lower the threshold or raise the threshold for seizures, does that stop the the presentation of seizure. That might indicate it is coming from somewhere, we just don't know where, but that the medication is taking an effect. Further than that, it comes down to, again, inserting electrodes directly into the brain and actually looking, is there something happening down there?
Absolutely. We talked about it a little bit, but clarify even a little bit more, and because I'm curious, what are some of the common misconceptions among patients or even providers about where a seizure, what a seizure looks like versus, where it comes from?
Yeah, I mean, I think the biggest misconception is that any shaking is a seizure. Or that if you don't see any shaking, there's not a seizure. I mean, that's the hardest part to explain is there are lots of false positives and false negatives. And you have to take not just physical observation, but EEG recording and other imaging to really determine, are these correlated, or am I seeing something that is only a downstream effect of where it's actually starting?
It's crazy in the neurodiagnostics world. It can be so easy to catch a seizure, the localization of it within seconds of the EEG being on, and then some seizures, a patient could go their whole life without capturing the seizure. It's incredibly frustrating.
Yeah, I mean, especially most of my in-hospital experience was at a children's hospital, and so you're not just seeing the frustration from the patient, but their entire family. They're just like, this is affecting our lives on a day-to-day basis, but we can't seem to capture it. We can't seem to prove it. And so it's a frustrating thing, but the better we do our jobs, the more we can narrow these things down.
What do you say to the parents whenever you had these patients who they were frustrated and maybe they weren't capturing the EEG? Were there any things that you were able to tell them to help comfort them, or?
I mean, I think a lot of the comfort came from telling them, you don't necessarily have to have a seizure while you're here. There is interictal epileptiform. We can see that there's irritated portions of the brain without an actual seizure happening, and also just making them feel heard and believed. Because I think that's what a lot of times their frustration comes from. Now no one just believes that this is even happening. They just think we're making it up, malingering, whatever it might be. But I would tell them, like, I believe you. Like, especially some of the stories I would hear were very convincing, and it was just like, okay, we need to figure out. Let's talk more about what precedes any of their events. Like, are they only happening at nighttime? Are they only happening after a late lunch? Like, can we try to reproduce some of the variables to maybe more effectively capture what we're concerned about? Because maybe it's just that it only happens in certain scenarios. And if we don't present those scenarios, we'll never capture it. And so we're just going to keep beating our head against that wall.
And when you say try to recreate these scenarios, like, what does an EEG look like whenever you're trying to recreate these scenarios?
So it may be the complete same. So it's more if they observe that it's only at a certain time of day, it's going to be pretty hard. Like, if it's always 3 p.m. to 4 p.m. and we only ever take patients from 7 a.m. to 11 a.m. We're probably not going to get it. So the EEG might not show anything different until the actual event.
So like a long-term EEG might be helpful in these cases.
Yes. So this is where an EMU stay is crucial. The routine EEG, sometimes it's great because you can capture what you need to capture in 30 minutes and be done. But there are times where you get multiple routines, you're not able to prove anything with it. And that's where you want to get the EMU stay. And then within that EMU stay, especially if they're going to be there for multiple days, you can start to recreate things. Like, okay, if I stay up late, eat sugar too late, and then play more than an hour or two of video games, it always happens around 11. You can do that in the lab, and we can try to recreate that. And maybe we start to see more interictal epileptiform as soon as they start eating sugar late. And then we see it get worse as they're stimulated from video games. And then as they get even more tired, that again lowers the seizure threshold, and then we start to see these things build up and then maybe capture one.
And then you can even, with the PNES, with the seizures that aren't necessarily originating from epileptiform in the brain, you can put some stressors on people with potential PNES.
Exactly.
Let's talk about that for a second. Like, what do you do to help a patient with PNES actually evoke a seizure on the EEG.
It's touching because you don't want to be conning anyone or trick them into anything and say like, oh look, I feel like I'm seeing something weird on your EEG to see if they're like, oh, let me prove that I'll make it even weirder. It's more try to recreate scenarios.
Like maybe talking about stressful situations or having a certain family member come into the room.
So if we find out the only person who ever reports seizures is grandma.
Yeah.
We want grandma to come in.
We want grandma in. Yeah.
If we see that it seems to always be like at nighttime after a patient talking to their significant other for a couple of hours and get into an argument, we'll just make sure they have that phone call that night. We just want to kind of replicate any scenario that tends to bring out that sort of behavior.
Yeah.
And see if we can capture it, because it's not like if it's a PNES event, it can't be treated. It's just treated a different way. It's you bring in someone who's not going to give anti-epileptic medications, so maybe some counseling, maybe some different things.
Yeah.
So replicating an event, whether it's true epileptiform activity or does not have a cortical origin, it can help with the downstream, like how we're going to treat that, how we're going to handle it.
Absolutely. And incredibly valuable for the patients too. Well, let's wrap it up. So what advice would you give technologists or early career neurologists when it comes to interpreting the semiology when they're looking at the EEG?
I think the advice is the advice that no one wants to hear, which is learn neuroanatomy very well. It's what, I mean, except for instrumentation, I think it's what techs dislike the most about like studying for boards is all of the neuroanatomy, all of that.
There's a lot.
There's a lot.
Yeah.
The more you do learn and get comfortable with it though, the easier it's going to be to make the connections, to understand the simple left hand, right central brain. When you can look at those things quickly or understand, okay, most of what they report are just sensations or weird tastes, knowing that you're looking for something in a different location than the motor cortex.
Yeah.
Just those basics, very helpful. Then if you want to start really getting involved with SEEGs and those interpretations, the more you know about your neuroanatomy and all of the different tracks, like how all of your different regions are interconnected, the better you can start to kind of put a roadmap together of, okay, maybe it starts here and it travels this direction, and we can look at how the symptoms line up with what we're seeing electrographically.
Yeah, absolutely. Now, how can, talking about caregivers, how can caregivers of patients really help with the documentation of what's going on when they see something happening at home? That way a neurologist can like look at it and maybe it can help add a little bit of context to what's going on with their loved one.
I think anyone with epilepsy or concern of epilepsy should keep a seizure journal. So we would encourage this with our patients at the Children's Hospital all the time, is you have a journal of activity, or a journal that anytime something potentially seizure related happens, you're writing down the time, the duration, what it looked like, what it felt like, what were you doing before, what were you doing after. The more you can log in that, the better. If it's a patient who kind of stays lucid during their events or mostly gets auras, they can document most of this themselves. They will need help if they lose consciousness to write down what happened. But that document over time, we can look at trends. Does it typically only occur after not sleeping well over the weekend? Is it always something that happens after work or after schoolwork during the day? The more detail you can provide, it's not only easier to replicate the situation in the lab if we want to try to get one of these captured on EEG, but it also just looks at potential lifestyle adjustments that can be made. Does sleep play a major role in it? Is it a dietary thing? There are a lot of things that keeping a journal can give you insight into about not just is this a seizure and how can we medicate it, but are there other changes we can make that maybe will lower the dosage of medication you need or things like that.
Yeah. No, it's fascinating that you said, the trends, because Dr. Elgovich, an epileptologist, a good friend of mine, re-emphasized to me that a seizure is a symptom of epilepsy. And it's not the actual diagnosis. You're not diagnosed with seizures, you're diagnosed with epilepsy, and there has to be certain things in the seizure happenings that are happening with you for you to be diagnosed with epilepsy. And so, it's fascinating to me that really it's the only diagnosis that can be provoked, really. I mean, flashing lights, stress, lack of sleep, alcohol, all these things can trigger the symptoms. It's real hard to, let's say you have pancreatitis. You can't really provoke the pancreatitis, right?
No.
You can provoke a seizure in epilepsy, and that's one of the fascinating things I love about this field of study.
Right. It's also like one of the scarier ones too.
Exactly.
Because you're never going to try to be like, I don't know if you really had a heart attack. Let's see if we can give you another one. With epilepsy, we're like, yeah, seizures are scary, but let's go ahead and do one real quick.
Let's do one more.
Yeah.
It's
a weird field to be in for that reason.
Yeah,
but you get a lot of valuable information because of it.
Brad, thank you so much for taking your time. Again, thank you. We're having a blast at Asset. Yeah. And I can't wait to do it next year, and we'll have you on next year if you want to.
All right, start researching now.
All right, sounds good. Well, thank you. I appreciate it.
Yeah, thank you.